We are starting a masterclass on diabetic retinopathy basics and beyond, a step-by-step approach. I'll request my co-panelists to join me, Dr. Dinesh, Dr. Rajiv, Dr. Vishal, Dr. Bhuvan. We can sit in the front. Sit in the front. 90 minutes, and we have enough time. We'll have interaction after each this thing.
Oh, Ajay, you're starting. Good afternoon, ladies and gentlemen. I think we will start so that we don't waste any time on introductions or waiting for people to come. Today what we are going to discuss is various aspects of diabetes which for this country are becoming exceedingly important because we are now facing an epidemic of diabetes and its complications. And among those complications, we are in the forefront of the management. In fact, a survey done in patients of diabetes it was found patients are more scared of the eye problems than they are about the heart problems. So keep it in mind. Don't think that the patient is bothered about his heart attack. He's actually more bothered about his eyes. And that is your responsibility. The patient doesn't bother whether you're a retina surgeon or an ophthalmologist. He knows you take care of the eyes. And it's your responsibility, regardless of whether you're a retina surgeon or not, to give him the right information. And Dr. Ajay Aurora has designed an excellent course, and I think his handout was so good that I actually felt that we might as well not do the course. But we have him here. He works in Delhi, and he's one of the foremost retina surgeons in the city. And it's basically his baby, and over to him.
Thank you, Dr. Dinesh, for the kind words. So welcome to the Masterclass on Diabetic Retinopathy. I have some great leaders in diabetes who are part of the course. They really do not need any introduction. Dr. Lalit Verma, all of you know, he's a great teacher, a great friend, and gives a lot of practical tips. My dear friend, Dr. Dinesh, he is a very sought-after speaker, always giving you the rationale behind everything. Dr. Rajiv, I have been reading all his papers since past many months. He has done amazing amount of work on epidemiology and some of the basic work on diabetes. He is a Shankar Netralaya. Dr. Vishal, he is a great friend who is based in Jaipur, a very prominent vitreoretina surgeon, has won numerous awards at ASRS. Dr. Ritu, who is happens to be my spouse also, she's a wonderful cataract surgeon. And I have stopped doing my cataract surgery. She does all the combined cases where we do it together. Dr. Bhuvan, a very great friend who is practicing in Delhi from AIMS, and a very prominent vitreoretina surgeon of North India. So welcome to the course. Now, this is what we'll be doing. We have about 90 minutes. After each talk, we will have about 4 minutes of discussion. At the end also, we'll be left with about 10 minutes if we space our talks well. So let me go through the epidemiology of diabetes. The definition of diabetes, all of you know, is a chronic metabolic disorder which is characterized by hyperglycemia resulting from defects in insulin secretion, insulin action, or both. Now, this is a standard definition, and if we look at 10 countries all over the world, the top 3 countries which have almost half of all the diabetic share in the world are China, India, and USA. And gradually, India is becoming the diabetic capital of the world. If we look at over the years, in 2021, 1 in 10 persons were diabetic. There are about 537 million diabetics in the world. In 2030, it will be 1 in 9, and by 2045, it will become 1 in 8. But just imagine, this is the diabetic whom we know. 1 in 2 people do not know that they are diabetics. So they are pre-diabetic. So that is the volume of problems that we have. Now, prevalence of diabetes worldwide, if you look at it, the global prevalence has risen from 4.7% in 1980 to about 8.5%, almost doubled in 2014. If we, of all this, 90% people are type 2 diabetic. In 212, the diabetic retinopathy in diabetics was 34.6%. Fortunately, in 2020, this has declined the percentage-wise to 22.7%, but overall the number of figures of diabetics has increased, which I'll share in my next slide. Now, if you look at the distribution of diabetic retinopathy, in 2020, this about 103 million had diabetic retinopathy. Of them, the sight-threatening diabetic retinopathy was almost 30%, and CSME was almost about 20%. This figure is a projected figure to 2045. Now, the estimates of diabetes in India, in 2000, we had about 80 million diabetics. In 2019, we had 77 million diabetes in India. The projected figure for diabetics in India in 2020 was 80 million. We achieved that target 10 years in advance. So that is the amount of the numbers that has grown. This year, the number of diabetics is 101 million, and about 136 million are pre-diabetic. Please remember, of these 136 million, about 45% are going to convert to diabetes. So I should not say that, but it's good to be a vitreoretina expert in these days, because the amount of diabetes which is happening is phenomenal, and there's a lot of work for us. But and in 2045, this figure of 130 million possibly is going to be achieved much earlier, maybe by 2030. Now, there is a very nice study which was published by ICMR. This is the 2023 data, which shows the prevalence of diabetic retinopathy and diabetes in India. And this figure I've already showed you, that how much is in 2023, 101 million diabetics, and pre-diabetics are 136 million. Now, why are Indians affected most? This is because of a typical phenotype which is postulated, called the South Asian or an Asian Indian phenotype, which is possible because despite not being obese, we are predisposed to more diabetes. This is because of a higher level of total visceral fat, higher waist circumference, hyperinsulinemia, insulin resistance, and greater predisposition to diabetes compared to the Caucasian population. The main driver has been that there is more urbanization, there is a change of diet even at the rural level, there is a reduced physical activity and increased change of diet. But the most disturbing factor, which is that younger people are getting affected. The study which I just quoted had done studies for population above 20 years of age, and that is definitely very disturbing. If you get diabetes below 40 years of age, the chances of your developing diabetic retinopathy are much higher. I will not go into the details, but there's a beautiful article which Dr. Rajiv has published on the role of systemic factors on diabetic retinopathy. You should go through it: age of onset, obesity, albuminuria, serum lipids, abnormal sleep patterns, hemoglobin A1C, the role of dietary fibers, anemia, the cardiovascular score, and neuropathy, and they are all very relevant factors. The worst part is that despite diabetes being so common, the awareness to diabetic retinopathy amongst the caregivers is very, very poor. Also, it is very poor in diabetics anyway, and that is something which we have to address. The paramedics in South Indian population, almost 50% of the respondents were not even aware of the risk factors of diabetic retinopathy. So it is very important that we need to screen more people, and we need to increase the awareness about diabetes, and All India Ophthalmic Society can certainly play a major role. There was a beautiful article which came up in BMJ, which told us about the cost of diabetic retinopathy. And if you look at these figures, they are mind-boggling as to amount of money that gets wasted because of inadequate treatment, suboptimal treatment, and not detecting these patients well in time. Therefore, there's loss of working working man hours with these patients. So the solution is we have to find out simpler methods of screening, and one of the methods which the Smart India study has proposed, and we are probably looking forward to carrying it forwards, is detecting sight-threatening diabetic retinopathy. If we have biomarkers which can tell us instead of screening 101 million people, we can screen only 30 million people, it will save us a lot of resources. Now, let me just, this is basically an introductory talk, so all of you should know about clinically significant diabetic macular edema, and you should know about that DRCR.net and European expert panel divided simply diabetic macular edema into center involving and a non-center involving. If you have a non-center involving diabetic macular edema, a focal edema, it can be lasered, while a center involving diabetic retinopathy needs to be intervened by intravitreal injections. This is a busy chart, but it's important to understand the pathophysiology and what all pathways are involved, because then these can be intervened. I'll share this slide. This was actually shared by Dr. Mangat Dogra from PGI. There was a patient who had refused to get intravitreal injections. This is a story which is almost over 15 years back, and he said he'll do diet control and yoga, and this is what happened after about 6 to 8 months. He responded well. So metabolic control is important at every stage of diabetes, whether it is the early stages or late stages, they must be done. This was one of our patients in the multi-specialty hospital who had come to us, had never shown a nephrologist, underwent dialysis once we saw the retina, and after 8 months the retina had flattened. So it's very important to control these people metabolically. Anemia exaggerates diabetic retinopathy. This was a patient who was thalassemic, and this was a patient I had operated almost about 14 years back. She did not have a hemoglobin going beyond 9 grams. We had given her multiple intravitreal injections, and then we went ahead and did a pars plana vitrectomy without a traction, and that improved oxygenation of the macula, and patient did well. Now coming to imaging in diabetic retinopathy, so these are some of the various modalities that we use. We must do a standard photograph because each photograph tells us a lot of story about what has happened with the patient in the past, what the patient is going through, and it is also an educational tool. You can demonstrate to them retinal hemorrhages, various types of retinal hemorrhages, exudates. You can even show the treatment results in case you go to laser them. And then angiography. So this was a 64 years old male diabetic patient who came to us. Looking at this picture, I cannot imagine that this will be a case of proliferative diabetic retinopathy. But this is many years back, before we could get the wide field angiography, we were able to demonstrate the NVE, and hence the treatment parameters changed and we were able to treat them. Angiography helps us to identify the capillary non-perfusion areas, so you have to have a good metabolic control and do scatter laser in these cases. And oral angiography, especially in patients who cannot give an intravenous dye or for some reason, then oral angiography can be done, and in a SLO-based system, you can actually get very good images. So the take-home message is that the angiography helps us to confirm the extent of macular ischemia, identifies leaking microaneurysms, confirms area of doubtful NVD and NVE, demonstrates area of capillary non-perfusion, and should be done in all diabetics when you see them for the first time, because it helps us quantify the disease when the patient walks into your clinic. OCT has become virtually the histology of, it's a live histology of retina where you can see all the layers. You can actually compare all the OCT pictures and corroborate it with a colored picture and show it to the patient. You can demonstrate a vitreomacular traction and you can show that that is not possibly responsible for the macular edema, like in this particular case. There are various patterns of OCT described and these are very well known. I think these are available in the textbooks. The spongy edema, partial thickness cyst, full thickness cystoid spaces, subfoveal serous RD, and each has a relevance from the treatment point of view because you can actually decide when to give anti-VEGF, when to do pars plana vitrectomy. Autofluorescence, we know that the vessels in autofluorescence appear black. The disc is again hypoautofluorescent because there is no autofluorescent material there, and the fovea, most of the thing is absorbed by the lutein pigment. So autofluorescence is picking up interesting observations when we look at diabetic retinopathy, because there are new techniques available which look at some of the other autofluorescent material which is other than lutein, which might be important in cases of diabetic retinopathy, and this has become part of a multimodal imaging. So this is a publication of 2021 which is actually looking at detecting fluorescence due to minor fluorophores, which could be like advanced glycation products, and that can help us understand what is happening at the retinal level. Coming to the last part of our wide field imaging, it was shown that the peripheral lesions are normally missed when you do a normal angiography. So this was a patient who came to us with a recurrent hemorrhage, underwent vitrectomy, and when we did wide field angiography, we were able to demonstrate NVE despite the fact that I thought I had done a complete laser, a large area of capillary non-perfusion. If I had not done this and done a normal photograph, I would have missed all the areas. So that is the advantage of a wide field imaging, which is useful in treating especially these cases and completing your laser in patients. This is another similar patient who had a peripheral neovascularization which got lasered well because we were able to do wide field imaging. So in the end, let me conclude that we are in the midst of epidemic of diabetes in our country. We need to wake up, screen our patients well. We need to gear up as a society and collaborate better so that we can deliver. Imaging is useful and multimodal imaging is really contributing for us understanding and treating the patients better. Thank you very much. I think we can go to the next and we can have, if you want to have anything, because this is an introductory thing, but yeah. If anything you want to point out, Rajiv, regarding the epidemiology.
I think you have covered everything, the epidemiology part.
Closer.
I think you have covered everything, and more recently the Smart India study has come out with the national prevalence, even the national prevalence of visual impairment. It's about 21%, which is fairly high.
Right.
And again reiterates it's not only diabetic retinopathy but even cataract. Ungradables, among ungradables there was high rate of visual impairment. Good, thanks. I will request Dr. Dinesh Talwar sir to talk on role of anti-VEGF in diabetic retinopathy.
Good afternoon, ladies and gentlemen. At the outset, I must thank Dr. Ajay Aurora for inviting me to be part of this session, which I believe is a very important topic for all of us. Before I start, this is my disclaimer and the financial disclosure. We all know today anti-VEGF agents are something we're using right, left, and center. And they've almost become a panacea for all retinal disorders. So for a microangiopathy like retinopathy, this should actually be just what the doctor ordered. But isn't that too simplistic? It is, because diabetic retinopathy is not one particular disease. It is a continuum. And that continuum spans the entire gamut from preclinical retinopathy with no changes visible on the fundus to advanced end-stage diabetic eye disease. And in between you have NPDR, maculopathy, and proliferative diabetic retinopathy. So if you look at it, the treatment points for diabetic retinopathy are there. You have to see at each level. No retinopathy or early NPDR, the main treatment revolves around medical treatment. So please don't under stress on that. I think that's what Ajay was talking about. But the important thing to stress is that you can actually get a huge amount of improvement in your patients merely by stressing on medical control. The next comes the role for active ocular management, which occurs in diabetic maculopathy, in proliferative diabetic retinopathy, and sequelae of proliferative diabetic retinopathy like vitreous hemorrhage. So what are the issues of management in diabetic maculopathy? The first thing which I want to talk about is the fact that people talk about lasers now being obsolete. And then the second thing is about the anti-VEGF agents, which to use when and how. And finally, whether there's a role for steroids as an anti-VEGF agent, as an intravitreal agent. Now, this myth about the fact that lasers decreases the visual outcome actually stems from the fact that in the DRCR net study and in the RESTORE study, they found that the patients who had a deferred laser had slightly better improvement in visual outcomes as compared to those who had prompt laser along with an anti-VEGF agent. What people don't realize is that if you do the subgroup analysis of these cases, there were two groups. One group in which focal lesions were there, and they obviously must have had a focal laser, and the other group which had diffuse diabetic macular edema, and where probably a grid would have been done. It is the grid patients, is the patients with diffuse diabetic macular edema in whom the vision dropped following laser. It was not those who got a focal macular laser. So focal macular laser does not adversely affect the outcomes, whereas a grid probably does. So this is very important to keep in mind. Now you say, why is it referent? Because we are only talking in terms of center involving diabetic macular edema. But keep in mind, when you talk of center involving diabetic macular edema, you could have macular edema which is away from the center but which goes right into the center. And the points of leak, the points of origin of the fluid in these patients could arise far away from the macular center. And all you need to do is laser for that macular edema to be taken care of. Unfortunately, nobody stresses upon this fact that even center involving diabetic macular edema can very often be amenable to treatment with laser. In fact, if you see the data, both in this RESTORE study and in the DRCR net protocol I, some 50% of patients had focal lesions which were amenable to laser. So not doing the laser in these patients would skew your treatment towards more and more injections. Now, when you have a patient with DME, your approach to management starts with BCVA. And the problem is everyone thinks BCVA is distant vision. No, it's distant and near vision. Remember, this is a macular pathology. Near vision can be N12 and the distant vision may still be 6/9. This patient still needs treatment. So the important thing is both distant and near vision evaluation. Along with that, you do the OCT, you give the anti-VEGF treatments to decrease the severity of the macular edema, but before you do consider doing a focal macular laser, it would be good if you do a fluorescein angiography. And then subsequent treatment can continue PRN in these patients. This is just to show a patient who had a combination of some leaks within 500 micron of the foveal center and others far away, given an intravitreal agent to first decrease the amount of edema, then done focal macular laser, and then subsequently you can continue with the anti-VEGF treatment. But before you do any such focal macular laser, make sure that your patient is controlled for as far as lipids are concerned. So no hyperlipidemia should be there. Now, which anti-VEGF should you use and when? This answer is very well answered by this question is very well answered by the protocol T. In patients whose vision is greater than equal to 618, ranibizumab and aflibercept are both equally effective. Now this is important to note because there are economic constraints and those get managed by knowing about this information. For patients with visual acuity less than 618, aflibercept monotherapy or maybe even an initial aflibercept followed by ranibizumab for maintenance may give you the same optimal results. And if there are economic constraints, please continue the patient on ranibizumab. Why not bevacizumab? Well, just to show you, in patients with good visual acuity, who have baseline visual acuity, the decrease in the macular thickness with bevacizumab was half of what it was with ranibizumab or aflibercept. So if I have to give a choice, I would give the choice of ranibizumab and aflibercept and not of bevacizumab. On the other hand, the poorer the baseline vision of the patient, the better the chance he has with aflibercept, if he can afford it. The other important thing to note is that there is no emergency for treatment. Even a delay of 2-3 months does not change the overall outcomes over 2 to 3 years, and so don't push your patients as if there's some kind of a tearing hurry for treatment. Get the patients to control their diabetes, get them to control their lipid profile so that the patient does a comprehensive management of his eyes and not just a piecemeal treatment. Now, how do you treat the actual patient on the ground? If his distant visual acuity is better than 612 and better than N8, conservative treatment is the way to go. I would only give topical NSAID drops. I would not start anti-VEGFs because we know once you start, he'll need something like 8 to 9 injections in an year. And with only minimum benefit, as we know from the protocol T. But would no injections make them deteriorate? No. This has been confirmed by the protocol V that these patients would not deteriorate over a period of 2 years in majority of cases. So the safest approach would be continuous monitoring till early signs of deterioration occur, and then you initiate the anti-VEGF treatment. Patients who have a decrease in distant vision or a decrease in near vision both require initiation of treatment with anti-VEGF agents, which continues PRN from initiation. It is not a loading dose of 5 injections. It is PRN from the initiation and continued till the patient gets a vision of better than 612 and a normalization of his foveal contour. And then you can stop his further treatment. If this endpoint is not reached, you can continue the monthly treatment till you reach it. And if you if you get no further improvement, you can stop, continue on follow-ups, or you can give a trial of steroids to these patients. Remember, 25% of patients, even with ranibizumab, do not need any injections after the first 3 injections. This is based on the RESTORE's trial. And these patients, whom you can call as elite responders, actually need just 3 to 4 injections in the whole year. The other important thing is, at the same time, there are 20% patients who will not respond through 2 years of treatment. So, if you have a patient who is not responding to 2 consecutive monthly injections, by not responding, I mean no change in visual acuity, absolutely no change in OCT, these patients should probably get a chance with treatment with steroids. The last group of patients in macular edema, those who are non-resolving, before you say non-resolving, rule out vitreomacular traction, and then you can give them a trial of Ozurdex for a sustained effect, followed by anti-VEGF agents for maintenance and prevention of recurrence. 4-weekly OCT is still needed, and you can see this was one of those patients not responding to any monthly treatments till he got one Ozurdex, and suddenly the response came, and this will usually end up with a rebound 3 to 4 months later. That's why the monthly follow-ups are necessary. When you come to proliferative diabetic retinopathy, you have 3 things in your armamentarium: lasers, anti-VEGF agents, and steroids. You need anti-VEGF agents or steroids in combination with your lasers to decrease the macular edema and get better visual outcomes. The protocol has showed us that you could do monotherapy with anti-VEGF treatment. But what was the main advantage? Lesser effect on the peripheral field. But if you actually go and check how much is the effect on peripheral fields, a study in UK showed they actually could all pass their driving test even after a PRP. And furthermore, I believe that in today's era, if we decrease the distance from the arcades, leave some area next to the arcades, maybe another 1 disc diameter, your 30-degree field would not be affected. Remember, in patients without DME, you need something like 7 injections with monotherapy in the first year, 10 over 2 years. But in patients who have macular edema with PDR, you need up to 14 injections in 2 years. And in these patients, if you add a PRP, these patients actually needed half the injection, 9 injections. Maybe there is a role for PRP to bring down the incidence of macular edema in patients also, which we need to keep in mind. So how do I manage my patients with proliferative diabetic retinopathy with maculopathy? If it's a raised neovascularization, I would complete the laser first and use anti-VEGF treatment later. If it's a flat neovascularization, I would give an anti-VEGF and quickly complete my laser, because these patients are very amenable to this combination. And if NVE is persistent after adequate laser, you need anti-VEGF agents. Probably the optimal treatment is a combination of PRP with anti-VEGF agents. Now, as regards monotherapy, what is this? Is that a good way? I think it's like catching a tiger by the tail. We know if these patients don't come for follow-up, they have a very high incidence of losing their eyes. So, monotherapy, only if you've counseled the patient about the need for 14 or more injections in 2 years, with the possibility of more laser, need for regular follow-up, risk of traction detachment surgery requiring surgery, and the fact that the number of injections can keep on increasing more in diabetic macular edema. So this is possibly more suitable for PDR without maculopathy rather than those with maculopathy. In patients with vitreous hemorrhage, we don't use anti-VEGF agents as a primary therapy, but use it preceding a surgical intervention 2 to 4 days before, and to bring down the incidence of a bleed during the surgery. Ladies and gentlemen, I conclude by saying judicious use of anti-VEGF agents as part of a multi-pronged attack can definitely help to preserve and improve visual functions in patients with diabetic retinopathy, possibly even indefinitely and even with optimal cost. So please make sure your patients get that and keep them seeing. Thank you very much.
Thanks, Dinesh. I think we'll have the questions in the end. Next speaker is Dr. Bhuvan. He'll be talking on current role of lasers in diabetic retinopathy. And we have the President of Australian Ophthalmic Society, Dr. Raymond, with us. I'd like you, sir, to comment later on once the course is over. Thank you.
So I'd like to thank Dr. Ajay Aurora for giving me this opportunity, and also AIOS. And as our previous speakers have already highlighted the importance of systemic control and the role of anti-VEGF in the management of DME, I'll be touching upon the role of lasers, the current role of lasers in the management of diabetic retinopathy, the conventional and the newer laser techniques, and the role of laser. However, I think Dr. Dinesh has mentioned some about the role of the laser, but I'll be highlighting further.
And anti-VEGF agents, traditionally have been the first line of therapeutic agents for the management of macular edema secondary to diabetes. However, all the literature suggests that almost 40% of DME patients show more than 3 lines of improvement with anti-VEGF, suggesting the role of multiple factors, that is inflammation in the etiopathogenesis of DME. So among eyes that showed limited initial visual improvement also with the anti-VEGF, only 20 to 30% of these patients show a clinically significant long-term visual response with continued anti-VEGF therapy over the next 3 years. So what is the role of anti-VEGF, of the inflammation in DME, in the causation of DME? So this is an algorithm showing, many molecules in addition to VEGF as a pathogenetic factor of DME, and primarily it includes addition molecules like ICAM and integrins. So besides VEGF, there might be various other pro-inflammatory agents responsible for DME. And in various studies, vitreous levels of VEGF, apart from VEGF, ICAM, IL-6 and MCP1 was significantly higher in diabetic macular edema than in the vitreous samples of non-diabetic patients. So it showed that the vitreous levels of these molecules had an influence of the retinal vascular permeability and the severity of macular edema secondary to diabetes mellitus. So, understanding more about these pro-inflammatory cytokines in DME will help future research of DME in identifying appropriate cytokines as biomarkers for individualized DME therapy apart from the standardized anti-VEGF therapy. So now coming to the question, is dexamethasone effective in inhibiting inflammatory cytokines? So these are the rat models, and in these studies, dexamethasone down-regulated expression of VEGF and ICAM1 in diabetic rats, and it correlated with the effect on leukocyte accumulation. And the data revealed that it inhibits retinal accumulation of these cytokines, specifically blocking VEGF in addition, specifically blocking ICAM in addition to VEGF. And the clinical trial settings also showed the same, and 0.7 mg and even 0.35 mg of dexamethasone implants showed more than 15 letters of improvement as compared to sham in all the cases. The important point further taking that is that eyes which switched early to dexamethasone implant had better visual outcomes at 12 months. Eyes which switched off after 12 months to dexamethasone implant from anti-VEGF also did well, but not to the magnitude of the eyes who we switched early in the course of treatment. So if there is so much evidence, why are we hesitant to give steroids early in the care of diabetic macular edema? There can be many reasons. Because in the routine OPD and routine follow-ups, we are basically unaware in our busy OPDs of the suboptimal treatment with anti-VEGF in our everyday clinical practice. Or there might be hesitancy because of the concern of side effects, increased IOP or cataractogenesis of corticosteroids. These factors are the primary reason we are not using as a first-line therapy in diabetic macular edema. So looking at the evidence-based medicine, now it has been established in many conditions corticosteroids are the first-line treatment. It can be used as first line in pseudophakic eyes. It can be used first line patients with cardiovascular events. It can be used first line in patients unwilling to attend or non-compliant to monthly injections. And it can be used in phakic eyes which do not have cataract and are not young and they're clear and crystalline. It is the preferred first line therapy in serious retinal detachments with HRF, hyperreflective foci, and many hard exudates. And again, it can be used as first line in patients who are comorbid and not suitable for anti-VEGF and cannot come for regular checkups or regular shots of their anti-VEGF injections. So it can reduce the treatment burden for individuals not able to come or cope up with the intensive anti-VEGF therapy, and is a valid first-line alternative to anti-VEGFs and should be the first choice in pseudophakic eyes. So the key takeaways in steroids in diabetic macular edema is it's the first line, of course, we all agree is anti-VEGF agents. But many patients fail to show optimum outcome with the visual response with even after intensive therapy and monitoring. Because inflammation also plays a very important role in DME, specifically growth factors, cytokines, and addition molecules. Intravitreal corticosteroids are used in the management of DME as they block the production of VEGF in addition to ICAM and interleukins. And DEX implant shows efficacy in the treatment of DME along with a favorable safety profile with very less chances of cataractogenesis and IOP rise. Coming to vitrectomy and DME, I will not cover anti-VEGF agents and lasers because that has been covered by other speakers in this instruction course. So there are three indications, of course. One is a definite indication which we have been doing for a very long time. That is a physical traction. That is a taut posterior hyaloid membrane, vitromacular traction, or a epiretinal membrane which causes a recalcitrant edema which is unresponsive to anti-VEGF or steroid injections. A relative indication is there is no traction but there is a recalcitrant macular edema more than 6 months after multiple anti-VEGFs or steroid implant. And now some studies have shown a treatment naive DME, people are doing vitrectomy and peeling the ILM or the ERM to reduce the macular thickness. All these surgeries yield, as we have seen, excellent anatomical results with reduction in central subfield thickness. And the rationale is vitrectomy improves the vitreous oxygenation, it reduces the amount of vitreous VEGF and cytokine levels, and ILM peeling is beneficial for anatomical resolution of DME and hypothetically visual improvement also. All in all, the common denominator is it leads to decreased subfoveal thickness. A couple of videos here. So this is a routine diabetic vitrectomy for a taut posterior hyaloid membrane. You need multiple stainings in these cases. After induction of the PVD, as you can see, there is a thick posterior hyaloid which is faintly stained with the triamcinolone acetonide crystals, and you can see that taut posterior hyaloid membrane being removed with the end grasping forceps. And mostly these are easy to peel and they come in one sheet. And the case is not over yet because there is underlying ILM also which does not get stained before the hyaloid membrane, the TPHM is peeled. We have stained it with BBG. This is the third dye we are using, and now you can see the ILM being peeled and clearly visible after 2 layers of removal. And as I said, the anatomical results are wonderful. This was a vitromacular traction because of TPHM, and the foveal contour was restored after the surgery. Another case of a thick ERM, taut posterior hyaloid membrane. Again, multiple stainings are used. Here we have used trypan blue to stain the thick ERM, and you can see the patchy staining because of the presence of a thick ERM over the fovea. This was not as easy to remove in one go as in the previous case, but still we managed to do a wide peel, and this is the membrane we were talking of which has been removed now. And again you restain with brilliant blue G, and now you can see the ILM here, and now this is very important, otherwise it will cause a recurrence, and I peel ILM in all cases where I peel the epiretinal membrane and further augmentation of some laser. Of course you have to be cautious in cystoid edema where the roof is very thin, and in this case we were peeling the ILM and it de-roofed the cystoid macular edema secondary to DME, causing a macular hole post-operatively. So indications and extent of these surgeries evolve with time, technology, and our viewing systems. And to go for a vitrectomy is now is not an easy call, because every vitrectomy, especially a diabetic vitrectomy, is not a straightforward procedure. Vitrectomy, although it's an important tool in the treatment of select cases of DME, especially those with a physical traction like TPHM or VMT or ERM. For treatment naive DME, further prospective studies are needed to define its role. The bottom line is you should explain to the patient, and you should yourself be convinced that even if the foveal contour is restored, a thinner macula does not correlate with improved visual acuity, and it should be made adequately clear while you are counseling. Thank you so much.
Thanks, Vishal. For paucity of time, we'll go on to the next speaker. We'll be having Dr. Bhuvan. He'll be talking to us on current role of lasers, and I'll request Dr. Ritu to be ready with a presentation after Dr. Bhuvan.
Yeah. So there was a technical glitch, but I think it was better because now we have discussed systemic control, we have discussed anti-VEGF, we have discussed steroids. So now coming laser, which was once the most important mode of modality, but now many people try to avoid it. So the main objective is, does laser still have a role in the management of diabetic retinopathy, or despite the increased popularity of the use of anti-VEGFs and even steroid agents, which have been mentioned by the previous speakers. So as I said, for decades, laser photocoagulation was the first line of treatment for both proliferative diabetic retinopathy and for diabetic macular edema. But why anti-VEGF agents have become popular is because they are much more safe, they're much more easier to use, and they have shown much more superior results, and also result in much more rapid improvement in vision. So just a brief, thing which I think all of us should be aware, especially the postgraduates. What is a high risk PDR? this is a definition of a high-risk PDR, which according to the DRS study, it said that if you do a pan-retinal photocoagulation, it reduces the risk of severe visual loss by 50% or greater. Hence, a pan-retinal photocoagulation for a patient of PDR was considered the treatment of choice. So these are the complications I think we all know which PDR can lead to, and hence it has to be managed in initial stages. And in certain cases, even if there is a minimal PDR, I think we do a PRP, especially because the patients are lost to follow-up here, and it has to be more done early if the patient is pregnant or one-eyed to salvage the eye. So in a conventional pan-retinal photocoagulation, we usually do 1200 to 600 burns over 2 to 3 settings, and each burn is about half burn width apart, and the size is from 200 to 500 microns with a duration of 100 to 200 microseconds. So the principle is to ablate the ischemic retina, reduce the VEGF load, which will prevent the further proliferation of the vessels. And this is the lens which is most commonly used, a PRP Mainster Whitefield lens, which is used for performing a pan-retinal photocoagulation. So why this concept of the problem with conventional laser photocoagulation? Because it is associated with certain disadvantages. This pain during it causes discomfort to the patient. There is a permanent retinal scarring which can lead to decreased color vision, peripheral vision, difficulty in driving, difficulty in night vision. It can lead to aggravation of the DME, and in some cases it can also lead to choroidal detachment and even elevated IOP. So the thing to avoid this is you can do multiple sessions. So this is another thing about laser. This is a targeted retinal photocoagulation, but ultra wide field imaging is important for that. In targeted retinal photocoagulation, we find the areas of the ischemia with help of wide field angiography, and only the ischemic retina that is present anteriorly is to be ablated. So this is a very effective therapy which I have done in some patients, but the important thing is here that the patient should be under regular follow-up, because as the ischemia increases, the laser has to increase. So it is even an important treatment modality for the management of certain cases of DME, in which we can treat the peripheral ischemia from where the VEGF is coming. So these are the modern laser techniques which help to combat the disadvantages which I mentioned. One is the pattern laser, which is the pattern scanning retinal photocoagulation. There are certain patterns which are available. It reduces the time, increases the patient comfort. So I'll try to be slightly fast because we are short of time. So the advantages of these, it reduces the treatment time, it increases the patient comfort, and it also has much more accuracy. Since we have got a well-defined pattern, we just have to press it once, and we can complete the whole laser procedure in one sitting. It also causes lesser collateral damage because the duration of the laser burns is less as compared to a conventional pan-retinal photocoagulation. However, since the effective laser is less, so hence it is also less effective as compared to conventional laser. The chances of persistent or recurrent neovascularization is much more higher with a pattern laser as compared to a conventional single spot PRP. The other is the Navilas. It is another technique. I have not used it, but in the literature it's mentioned. It's not used very widely. It's image-guided laser therapies, which can be used both for proliferative diabetic retinopathy as well as for management of diabetic macular edema. So you use infrared images, color photographs, and the fluorescent angiography images, and we can give a predetermined laser treatment in a highly precise manner. So it is effective both for the management of PDR as well as for the management of DME, and studies have shown that it effectively reduces the macular edema over a period of 12 months with increase in visual acuity also. So as anti-VEGF role has been mentioned, just mentioning about protocol S, which said that you give every month intravitreal ranibizumab for the management of PDR. But however, this thing is not viable in our country, and it's not financially as well as medically viable for a diabetic patient who's already not systemically well to come for a frequent follow-ups. Also, there are complications that are associated with each injection. Hence, for PDR, PRP is still the gold standard, and a good PRP will result in a regression of the proliferative vessels. Now, coming to the second part, diabetic macular edema. So again, just the past theory, which I think everybody should be aware, what is CSME. This is a definition of the CSME, which is very important for a lot of postgraduates to know. Now we are just concerned about the center involving DME and giving anti-VEGFs, but we should be aware what CSME is for the management of the diabetic macular edema. So this is the ETDRS study, which said that CSME is based on slit lamp biomicroscopy. It differentiated it into a focal leakage, for which we did a focal laser, a diffuse macular edema, for which a macular grade is done, which I don't think now is needed in the advent of the anti-VEGF agents. You can give anti-VEGF, they give more superior response, but focal laser definitely has a place. And the second is macular ischemia, in which the FAZ is enlarged, and despite treatment, the vision will remain less. So according to the ETDRS, the laser reduced the risk of moderate visual loss. It resulted in some gain of vision, but however, it was also associated with increase in the size of the scotomas and a decrease in vision, and even there were some cases of reported secondary choroidal neovascular membranes. So hence for DME, the management first line is anti-VEGF agents. The second line would be probably steroids or a combination therapy, and laser definitely plays a role, as can also be seen in protocol T, in which both aflibercept and ranibizumab were given. But lasers in DME will have a rescue role. So maybe when the inflammation, when the swelling has come down, you can do an angiography, spot the areas of the focal leakage, and do a laser. That will not only reduce the number of injections, but sometimes even the patient completely gets rid of the intravitreal drugs. So as I said, both the pattern laser can be used both for PDR, PRP, as well as for the focal laser in diabetic macular edema, and similarly the Navilas. So these are other laser therapies which can be done especially for diabetic macular edema. The selective retinal therapy is microsecond pulses. And this is a very short pulse duration of a very high temperature that is just confined to the RPE. The melanosomes in the RPC, they absorb it, and it prevents damage to the overlying photoreceptors, neurosensory retina, and the choroid. So because of this selective treatment of the RP cells, the collateral damage and the formation of the scar chances are very less. Similar to this is the subthreshold diode micropulse laser. I have not used it. Dr. Ajay Aurora has used it. I think he will comment better on it. It uses a near infrared diode laser, and the principle is same like a selective retinal laser, in that it causes selective damage of the RP cells and sparing the overlying photoreceptors in the neurosensory retina, leading to no visible intraretinal damage or scarring, and also helps in the resolution of the DME. So this is a summary of the whole presentation, in which a pattern laser and navigated laser, which are newer modalities, which can be used for the management of both PDR as well as DME. They result in a shorter duration treatment and increased patient comfort. And the diode laser and the selective retinal therapy is used for diabetic macular edema, which will lead to minimal collateral damage and selectively causes the absorption of the laser at the level of the RPE. So laser has become the second line of treatment for the management of DME. For PDR, it is the first line, still PRP, and for DME, it has become the second line of management, where anti-VEGF is the first line. But however, as previous speaker has also highlighted, that a good glycemic control of the anemia, control of hypertension is very important. And if you're doing a laser, then we have to be patient, because laser usually takes 2 to 3 months, and even sometimes up to 6 months for the whole effect to come. And when can we use laser as a first line therapy? When intravitreal injection is contraindicated, probably a high cardiovascular risk, patient has got elevated IOP, you can't use steroids also, so probably we can go ahead for a laser only. And if there is a non-center involving DME, which is also comes under the definition of CSME, a laser can be done away from the fovea, and it can completely avoid the need of injections in the future. So just to conclude, laser is still the gold standard for the management of PDR in the form of doing a panretinal photocoagulation. There we have got newer laser techniques to enhance the patient comfort. Anti-VEGF drugs and steroids are the mainstay of treatment for diabetic macular edema. However, laser, especially focal laser, has a definitive role, even as a rescue treatment in several studies. And SRT, selective retinal therapy, and diode, subthreshold diode lasers are novel laser techniques which are used for the management of DME, in which they minimize the collateral tissue damage. So with this, I conclude my presentation. Thank you all for listening.
Thanks, Bhuvan. I'll request Dr. Ritu to talk on cataract surgery and diabetic retinopathy, and Dr. Lalit has just walked in. Can I request Dr. Lalit to come in front, sir? We have a chair for you here.
At the outset, I'd like to thank AIOC and also Dr. Ajay for including me in his very popular course. It's, I think, the second or third year running, and we've always had house full. So I'll be talking about the management of cataract and diabetes, how to optimize the outcomes, the timing, technique, and the choice of IOLs. As has already been told by my previous speakers, that diabetes is increasing in India, and as we know that it is 2 to 5 times, cataract is 2 to 5 times more frequent in diabetic patients than in our non-diabetics. It also occurs more rapidly at a younger age, and at any time we'll find that at least 1/4 of all our cataract patients are diabetics. Many of them discover that they have diabetes when they come for cataract surgery. Now, in order to optimize the visual outcomes, these diabetic patients really need a special attention. Now, the indications of cataract surgery could be a patient who has an advanced cataract, who has a poor visualization of the retina, and in order to monitor the diabetic retinopathy, to laser the patient, or to manage the diabetic macular edema, we need to have a good visualization. It can be a part of the vitreoretina surgery, and it can also be, as we know, diabetic patients are more prone to glaucoma, so it could be as part of treatment for either narrow angle glaucoma or even neovascular glaucoma. So what are the main concerns? The main concerns are that there's increased chances of post-op CME. There could be a worsening of a diabetic macular edema and a progression to PDR. As we know, diabetic patients are more prone to inflammation, so inflammation can be increased after the cataract surgery. And there's also increased risk of infection, especially when patients are poorly controlled, because it's not just the fasting and PP sugar on that particular day, but it depends on how good is their HbA1c, how good is their diabetes control, both pre-operatively and post-op. So the surgery can be challenging, especially when the patient has undergone multiple intravitreal injections or has had a previous VR surgery, and it needs a special experienced hand. So we need to do a comprehensive management, taking care of the preoperative, intraoperative, and the postoperative concerns, and look out for all the comorbidities, especially the systemic morbidities, which need to be taken care of. And coming to the ocular morbidities, again, we need to do a very detailed examination of the anterior segment. It's good to have a vitreoretina surgeon by your side when you're handling these patients. So having a good metabolic control is important. And what has been said by, I think, AIOS has defined that the fasting blood sugars should be less than 140 and PP should be less than 180, at least definitely less than 200. And many of these patients who have, NPDR, if they get well controlled on their metabolic control, we can see that, these patients are then better suited to undergo cataract surgery. So this is one of the patients who underwent a good metabolic control, had a very stable retina, and this kind of case is now can be taken up for cataract surgery. So preoperatively, we need to check the HbA1c, and every little bit counts. So counseling your patients to have a better control is important. Looking into the anterior segment and doing a detailed evaluation is very important, as these patients are more prone to inflammation, to ocular surface disease. They may be having iris neovascularization. If you see your patient undilated, it's important, because a dilated patient, you may miss an NVI. And there can be coexistent glaucoma. These patients do have poor pupil dilation, making the surgery more challenging. They also have poor endothelial dysfunction, and so we need to be more cautious when we do our surgery. And with the repeated intravitreal injections, many a time they have zonular instabilities. So controlling the inflammation preoperatively is important, and ideally we can start NSAIDs about a week preoperatively and continue that 4 to 8 weeks post-op. Stabilizing the ocular surface is also important, as these patients are prone to corneal hypoesthesias. They have more MGD and delayed wound healing. So these unstable tear films will also hamper your biometry and make your keratometric readings variable. So giving them lubricants, low-dose steroids, warm compress, or even advising them an IPL or LipiFlow prior to surgery is important. Looking out for NVI, as I said, is critical because it indicates that a patient in whom you cannot view the retina may be having a PDR, and such patients would require some treatment immediately after cataract surgery. So you can plan that you may like to suture the wound in such cases, because if you are planning some intervention, either laser or intravitreal injection or a VR surgery where you cannot view the retina, so you need to make sure that your wound is stable. So, coming to glaucoma, if the patient is just on a single medication, we could go ahead just for a cataract surgery. But nowadays, we see that patients who are on multiple medications, you could combine microincision glaucoma surgery along with your cataract surgery. Or if the patient is on maximal medical therapy, you may like to go for a phacotrap. So depending on how good is the control, how compliant is your patient, accordingly, you can decide whether you want to go for a combined surgery or a sequential cataract and glaucoma surgery. So the preoperative assessment is always of the posterior segment very critical, and documentation has already been specified. It's not only medico-legally important, but it's also important to counsel the patient for the future and to prognosticate the kind of visual results which are likely after cataract surgery. So any treatment that we do, ideally the posterior segment treatment should precede the anterior segment treatment, provided that the visibility is good. And also depending upon the grade of cataract, whether it's an advanced cataract or an early cortical cataract, that itself would also help us in deciding the timing of cataract surgery. If the cataract is not so advanced and you feel that the patient may require intervention for the vitreoretina earlier, you may decide to do an early cataract surgery. But however, if the patient has maculopathy or PDR, you may like to first treat the posterior segment or do a combined cataract and VR surgery. So the intraoperative management is important because these patients are challenging. They have poor pupil dilation. They have endothelial dysfunction and zonular instabilities. So we must make sure that we use a good viscoelastic. We must coat our endothelium. Make sure that you do a less traumatic phaco, and also keep in hand your pupillary expanders, iris hooks, and CTRs, because at any point these may come in need. The kind of IOL that we choose will also depend upon whether the patient is wanting to do a monofocal lens, or in this era of multifocal lenses, patients do insist many a time. But we need to again see whether they have any posterior segment involvement, in which case a multifocal lens would not be the best choice for them. Mostly we like to choose hydrophobic acrylic lenses which cause less PCO, and these cases, if they go on to VR surgery, also the silicone oil adherence is less to hydrophobic lenses. So biometry, of course, is critical, especially where the patient has already undergone an RD surgery. We need to make sure that we do an accurate biometry, and also try to avoid using AC IOLs or iris fixated lenses. So we know that even an uncomplicated phacoemulsification can be more challenging and can have more complications, more inflammation. So it's important that whenever we are dealing with these kind of patients, it should be undertaken by an experienced surgeon. So few intraoperative pearls that I would like to specify is that you may like to do the patient under peribulbar anesthesia. The rhexis should be of optimum size, as these patients can undergo capsular phimosis, and also you would like to visualize the fundus post-operatively. A good viscoelastic I've already mentioned. And in patients who've undergone multiple injections, you should be careful about the hydrodissection, because some of these patients who've undergone vitrectomy could have a posterior capsular defect. The zonules are often lax, and we should have CTR available with us. We should do a very meticulous cortical cleanup so that we avoid an early YAG capsulotomy, and the lens should definitely be in the bag. A good viscoelastic removal to avoid post-op spikes is important. And in case you plan to do a combined surgery, or if the patient needs a laser in the early post-op period, do suture your patients. So giving aggressive anti-inflammatory, good amount of lubricants, and a close follow-up with your retina consultant in the post-op period is important. So my take-home message is that even with diabetic patients, we can have excellent results if we take a well-controlled diabetes, stable retinopathy, and if we manage the preoperative morbidities well. So early surgery is good before the patient develops any posterior segment involvement, and in case the patient is having any posterior segment, has diabetic retinopathy, we need to counsel the patients that the treatment does not end with cataract surgery. The patient must come for regular follow-up. Thank you very much.
Thanks, Dr. Ritu. Now we have none other than Dr. Lalit. He'll be talking to us on vitreoretinal surgery in PDR, timing, technique, and tips. So he'll be giving us all the practical tips of how to manage these cases surgically. Rajiv,
Thank you, Ajay, for conceptualizing this widely appreciated course year after year. My job is to speak about PDR and its complications. You see, India today is home to the largest number of diabetics on the earth. There is 101 million, which is surpassed. A couple of months back, we used to talk of 77 million diabetics, but today we are 101 million diabetics. Nobody, no ophthalmologist can escape not seeing diabetic patients, and we all know the blindness, the moderate visual loss in diabetes because of maculopathy, and PDR causes, or the sequelae of PDR, not PDR, but sequelae causes severe visual loss. As was nicely emphasized by Dr. Bhuvan, that in PDR, a good scatter laser photocoagulation has saved so many eyes. You see, decades and decades back, we used to do laser, and those patients are still maintaining 6/6 vision. Anti-VEGFs are trying to poke in everywhere, actually, in all stages of diabetic retinopathy, be it PDR, be it diabetic retinopathy. But the issue with anti-VEGF is repeated injections are required. Cost is another issue. Multiple visits is another issue. What I would recommend is, whenever multiple injections are required, it's better to that you go in for early vitrectomy rather than keep giving injections in the eye. You see, this was the study, protocol S study, which tried to shove in injections even in PDR. And what this study showed, even 5-year follow-up is available, that is non-inferior to and a reasonable alternative. But the problem is of multiple injections. This is how I use in PDR injections. You see, a patient who has massive fronts, big fronts, but good vision. This patient, you may inject ranibizumab, but ultimately laser has to be done. There is another patient, one-eyed patient, who has a lot of fronts at the posterior pole. And like Bhuvan was saying that, you know, laser is still the mainstay of treatment. So here, one injection and then after laser. So now I will be touching something about vitreous surgery in diabetics. At the outset, all membranes do not require surgery. Nasal TRD and macula not being threatened, you can easily observe. Believe me, diabetic vitrectomies are one of the most complicated vitrectomies you face. So aim should be not to do any harm to these patients. So this is one patient who has been under follow-up for a long time. Since the macula is good, 6/12, easily follow up. This is one patient who requires surgery, but somebody gave injection in the eye, and once patient has massive TRD with rubeosis, then you easily refer it for VR surgery. So indication of vitreous surgery is no longer that non-resolving vitreous hemorrhage. Vitreous hemorrhage is one of the indication, but today most of the indications are evolving about macular TRDs or combined detachments, or even sometimes non-responsive macular edema, tractional macular edema. So I'll just begin with showing one or two videos with some kind of tips. This is a non-resolving vitreous hemorrhage patient, but multiple recurrences, 3 recurrences in a year in this young lady, IDDM lady, bilateral vitreous hemorrhage. So after the vitrectomy, you see this was the source of vitreous hemorrhage, a massive fibrovascular front on the disc. One should be very careful that do not taper it down to the disc, otherwise if it bleeds, you will have a tough time. So then we shift to the rest of the retina, do as much peripheral dissection as possible. But the reason I am showing this video is that the surgery took not 10 minutes. The macula was very good, the disc was very good, potential of vision seems to be very good, 6x6 kind of stuff. But 25 minutes I had spent lasering this eye. 10 minutes surgery, 25 minutes laser. And I would definitely want to emphasize that laser, once you do not do tuck, tuck, tuck here and there, but follow the vessels. Then you will not have any skip areas. And this laser is done all across. This is that, line drawn here so as not to go inside the posterior pole. So as you see, how much time is being spent on laser, because I still believe ultimately a good laser will ultimately save this eyes, not injections in this particular patient. So this is the scene at the end of surgery, that I said 10 minutes surgery but 25 minutes of laser job, and this is how a good scatter laser photo. So in this patient, since there was not much detachment, nothing, so we just did an airflow exchange and came out, no gas or no oil. So this was the post-op result in the right eye, and even in the left eye we had good result. So this is another video where this is again a diabetic. In a diabetic, the key step is to identify the hyaloid. Once you identify the hyaloid, then I think half the job is done. So here we have identify the hyaloid, and once you make a hole in the hyaloid, the loose blood from the retrohyaloid will, you can suck it out or aspirate it out, or maybe passively it will come out. So once we create a hole in the hyaloid like is shown here, this loose blood is being passively taken out. And then you address the membranes, various membranes on the surface of retina, and see how much adherent they are. More adherent means they may require bimineral surgery or some precautions. Also, there may be some iatrogenic ooze during the surgery. You should pay attention to this iatrogenic ooze immediately, otherwise this will form a membrane which will become very difficult to take it out. So with the help of back flush, take out this fresh blood from the surface of retina, and the loose membranes can easily be pulled up. But tough membranes you can't pull. So in diabetic membrane, don't pull too much, because if you pull too much, two things can happen. One is break formation, other is bleeding. So we should avoid all these complications in diabetic vitrectomy. Do not pull too much. So this is the scene at the end of surgery. You have this maculopathy and florid PDR. So we did airflow exchange and came out. Other indication of MIVS in diabetes is a non-responsive or a tractional kind of macular edema. So here again we do a combined surgery, cataract plus vitrectomy. Here the job is much simpler because you just have to take out the hyaloid and a associated epiretinal membrane. So this patient we did tricord assisted removal of the hyaloid, and since media was getting hazier, you could see this posterior subclavian cataract. Called in the cataract surgeon who did a very good cataract surgery, and then we go back again. So I stain these membranes with the help of trypan blue, the epiretinal membranes, and then identify the edge with the help of this old MVR blade. Old MVR blade will always have a small bend or a micro pick. Then you identify this membrane, because the key step here is to identify this plane. Once the plane is identified, then you take hold of Eckhart forceps and take out this membrane. And after that you can stain with BBG dye, because BBG dye will selectively stain the ILM, and the removal of ILM ensures that all the pre-retinal membranes have been taken out, and there is some data available which shows that if you remove ILM, the post-operative formation of further membranes gets reduced. So this was the last ILM removal. This was another diabetic patient here. In contrast to the first two patients, this cord was very tough, and you had to, take a calculated decision because it is in the unimportant area in the inferior nasal part. Fortunately for me, this with suction, this did came out, but I did not clean the entire this thing because I'm bleeding quite a bit. We did diathermy to this and left it, but fortunately this patient recovered 6/12 vision. And after you have dissected, then you do diathermy, because no diabetic vitrectomy you can start without the availability of diathermy. Most important instrument at that time is diathermy, because repeated rising of IOP has the negative effect of causing damage to the optic nerve. Remember, the optic nerve is already damaged in these patients. And this is the last video here where we did this dissection. Most of the areas we cleared, but in this left eye, the nasal part of the membrane we could not. So therefore, what sometimes we do is that we shift the ports. So this was inaccessible. So we shifted the infratemporal, that is the infusion port, to upper nasal, and also shifted the operating chair so that what was nasally now becomes inferior for me, and then accessibility improves. Then you can remove this membrane in a lesser possible time with less of complication. And this same membrane now, it is inferior. And after we have done this, we come back to the original position and do the rest of the vitrectomy. This was a young IDDM patient who had combined detachment, combined REG plus TRD. As I said, the key step is to identify the hyaloid. Here, after 15 minutes of struggle, hyaloid could not be identified. So therefore, this you see, there is a break here, and there is a bullous detachment here also. So this was the frond on the optic nerve head. So with gentle lifting of this frond, very gentle, don't pull it too much. Gentle lifting creates a space where you can then insinuate your 25 gauge cutter beneath, as is shown here, so that now you have island formation. So once this is cut, then you move along the various folds of the retina and take this along these various folds and use multiple instruments to do a lot of segmentation. No peeling should be done in such patients because you will land up in multiple problems of break formation as well as bleeding. So two B's have to be avoided, breaks and bleeding, as far as possible should be avoided. So after this was done, then just to make a judgment what's happening now, injected a PFCL bubble to stabilize. You see multiple islands having been created, segmentation done. After that, shifted to a bimanual surgery. So same patient, insert this 25 gauge chandelier here now. Believe me, bimanual surgery, even in this era of 27 gauge or 30 gauge, has a definite place, because I feel bimanual surgery adds precision. You can lift up with one hand and identify the fibrovascular attachment and then cut it with the help of curved scissors. Curved scissors is one of the most useful instrument in a diabetic vitrectomy. Or you can have, sometimes diathermy or sometimes cutter also, but I find curved scissors to be the most useful instrument. And if you are careful, believe me, bleeding and breaks are reduced to minimum by this bimanual procedure. So we'll just make it fast forward. So this is the same patient, curved scissors being used to identify. You have to be very, very patient in such patient. You can't rush, because therefore I normally keep a diabetic vitrectomy at the last case of surgery, not at the first. If you keep first, rest of the cases may get cancelled otherwise. So this was another patient, diabetic. The reason I am showing this patient is that, again, hyaloid, plane may be difficult. So here, instead of using old MVR blade, we use a sharp MVR blade and incise this hyaloid. It looks quite riskier, but believe me, macula is way down, because you have to study the pre-operative OCT as well as ultrasound. And then once this has been cut, then you do the rest of the surgery with the help of segmentation and scissors, as I had shown in the previous video. So, thus to conclude, bimanual surgery, as I said, has a place even in the era of 27 gauge or 30 gauge, because it adds precision and less of complications and better hemostasis also. So this is that lady whom I had shown pre-op the video, left eye as well as right eye. There are a couple of more patients. You see, ultimately visual recovery will depend on the health of macula and the optic nerve status. So therefore I am not very keen to always raise the bottle height to 60 millimeter for multiple times. Once a while you can do it. This is another patient. So thanks to the health of macula and optic nerve, patient got 6 by 6 in both the eyes. So thus to conclude, pre-op assessment is very important. Pre-op anti-VEGFs you can give, especially if the fronts are angry looking or red colored, and they should be given at least 1 or 3 days before the surgery. And also inquire the history of blood thinners, because a lot of these patients are cardiac patients and they are on multiple blood thinners. So I would like to avoid, because surgery sometimes may become messy. So it's not a simple procedure because PVD is difficult. There are multiple tenacious vascular attachments. Because they're vascular, they bleed, and because they're tenacious, you tend to have break formation. So the solution always is work very slowly. Do not pull too much. Do more of segmentation. Patience is the ultimate key, and newer probes with faster cutting rate, with port closer to the tip, does make the job much easier, and bimanual surgery does help in a lot of these patients who have tenacious attachments. Thank you very much for your kind attention.
Thanks, Dr. Lalit, for those wonderful tips. You know, you have those one-liners, those two words, which actually stay in your mind, which are very, very good. We'll have the last talk by Dr. Ajay. We'll be talking, so all of you have experienced the chat GPT, you've experienced about AI. We know that in 2 to 3 years, the AI is going to really change our lives. So none other than Dr. Ajay, who has done so much work for Google, so much, and he's probably the most credible person to talk of AI in India. He's done a huge amount of work, a lot of publications. So he'll be talking to us on AI and diabetic retinopathy, current status and future prospects.
Thank you. Thank you, Ajay. And this is the last talk of this symposium. I hope everybody has really enjoyed. And last, can you? Yeah. So I'll be talking on AI in diabetic retinopathy, what is the current status and what are some of the future prospects. So definitely there are certain tasks which AI ML has been doing very efficiently now, that is classification task, presence or absence of diabetic retinopathy, grading various diabetic retinopathy scales, and presence or absence of center involving DME. Because it can very effectively and very accurately do these, definitely it has a role in screening diabetic retinopathy. Besides that, now more and more work is happening on predictive tasks in diabetic retinopathy. Could be detecting OCT-based DME from a retinal image, or using other tools to identify diabetic retinopathy, creating some risk factor engine which can predict the chances of developing DR, or a OCT response of treatment, and more so now, lot of systemic diseases like neuropathy, anemia, cardiovascular health from retinal images. People are working on these predictive tasks using AI. All India Ophthalmological Society and Vitreoretinal Society of India came out with these screening guidelines last year, and it has included AI for diabetic retinopathy screening. And as we don't have any legal framework, it's also empirical that the ophthalmologist grades all the images which are called as referable by AI, and also 10% of normal images should be graded by a human grader. Very happy to share that very recently, last month, we have another guideline coming out from VRSI and RSSDI. These are the guidelines for physicians. So even we have now physician guidelines for using AI for diabetic retinopathy. There are certain landmark studies, and the first one was in 2016, led by Google, where Shankanetrale, we were part, and Arvinda Institute was part. It was the first work which used the deep learning for DR screening, more than 128,000 images, and it could detect sight-threatening retinopathy, referable retinopathy with a good accuracy. The very next year came a nice paper from Singapore National Eye Center, and that not only identified DR but also other diseases in the eye. But between 2016 and 2024, there have been major changes in AI. We have better deep learning models. We have some technology called as transfer learning, making sure that we really don't need these lakhs of images to train an algorithm. Even with a smaller number of images, algorithm can be trained. And more recently, we have now generative AI coming up, which has really transformed the way AI has been looking today. This was one of the paper where we were part. This came just a couple of months back, where this was actually a work done by Professor Tin Wong, and the Indian data set was used also in this to look into, can we predict the time of progression for diabetic retinopathy, and we were part of it, and we could very accurately even find out that what happens to a person in 4 years. Generative AI has actually an encoder, and generative AI, all of you must be aware about the chat GPT, Dr. Ajay told. So these are called as foundation models. It has a decoder, and it has multiple possibilities. It can be used for diagnosis, question answers, we all use it. It can summarize, it can also analyze the image, it can be used as a predictive modeling. So a lot of scope is there. And the first ophthalmology specific, so ChatGPT is not a ophthalmology foundation model. The first foundation model was by Dr. Pierce Keen Group, who made this nice foundation model, and many of the publications today are using this as a base for generative AI in ophthalmology. We have heard from Dr. Ajay the first talk. There are a lot of challenges in implementing AI for diabetic retinopathy screening in India. We have so many diabetics, and each one of them having annual eye retinal evaluation is a big challenge. It is a task next to impossible. We don't have so many cameras, we don't have so many people to take the image. And definitely there can be possible solution. Can we screen high risk individual only? Or can we identify high and low risk of progression and then probably customize their follow-ups? So let's see the first one, how AI has helped in screening high-risk individuals for presence of DR. So what we did, we tried looking at all the population-based studies from India. So we looked into the Shankar Nethralaya study, the Arvind Eye Institute, the LVP study, and the Mohan Diabetes study. We took the raw data from all of these studies and created a risk factor engine. We used something called as Shapley methods, which is more used for gaming, and we identified the top 9 risk factors for diabetic retinopathy, and then made an AI model which was reasonably accurate, a decision tree giving an accuracy of 0.8 AUC to detect presence of DR. That means without a retinal image, using these risk factors, we can probably reduce the number of patients who will undergo a retinal photography. We also tried using ChatGPT to do this risk assessment. Very small pilot study, not a very encouraging result because it's not meant for ophthalmology, but it could predict the risk of DR based on clinical and biochemical factors. The second is, can we identify the people who are at high and low risk of progression so that we can customize the follow-ups? And this was the paper which came in Nature Medicine 2 months back. And it was pretty different from our JAMA paper in 2016, and then the SERI paper which came in 2017 used much better AI algorithms, used transfer learning, online models, and had a real-time feedback. And in this, we had patients who had 4-year follow-up, and then we tried looking at what is the personalized screening interval we can see, and based on that, we stratified them into a high risk and a low risk group. And these are the AUCs across all the external data sets, and it showed very high accuracy in detecting the risk of progression and how much it will progress. So basically it also was combined with a GPT model which could also give a report suggesting that what is the possible way this patient has to be managed. So when we used on the Indian data set, we could reduce, so here the average screening interval, we tell patients they need a yearly checkup, but when we used that, the average screening interval of 31 months, we could extend maximum. That means a patient, we can say, no need to come for next 2 years or more than 2 years. That reduced nearly 61% reduction in the frequency of screening, and the delayed detection, the rate of delayed detection of any progression was only 0.37%. That means using this algorithm, first time we can say that you can come more relaxedly, no need for, so that reduces the number to be screened. It's a double-edged sword, so definitely there are a lot of limitations of using AI. Some of the challenges have been the data quality, the quantity, data imbalance. Many times you have very less cases, huge controls. The interpretability and explainability has been solved to some extent using the heat maps, and definitely the computational cost. There are certain inherent problems like overfitting. The model becomes so good in the training data set, it masters every pattern, even the noise is recognized, and it performs very poor on a validation data set. Sometimes you get what is called as a catastrophic interference, where it totally forgets what it has learned before. So you can have that. Sometimes there can be exploding gradient problem. I'll not go in detail. Adversarial attacks are something like what you get the viruses type of a viral attack or an adversarial attack, it can confuse the ML model and causing it to make more errors. ChatGPT, we know hallucination is a major issue. Factuality is a problem. This example, all these numbers are wrong. So ChatGPT imagine things, and people are trying to solve this problem to some extent. Besides that, data security, we have seen hallucination, ethics, bias, and the training data set and IP issues are always there because you use so many different diverse data sets. That is a problem which is always there. I would encourage all of you to go through this. One of the IGO publications we did was on AI in diabetic retinopathy. What are the policy implications, where we spoke about the advances in the AI, balancing the potentials with concern, the policy framework necessity, and the human-centric and ethical AI. I would end the talk by this. I'm sure many of you would have heard Mr. Geoffrey Hinton, the godfather of AI, who quitted Google. This is a small part from his interview, what he talks. Volume, can you increase?
And very few examples of a more intelligent thing being controlled by a less intelligent thing. And it knows how to program, so it'll figure out ways of getting around restrictions we put on it. It'll figure out ways of manipulating people to do what it wants. And I want to sort of blow the whistle and say we should worry seriously about how we stop these things getting control over us. And it's going to be very hard, and I don't have the solutions. I wish I did.
So definitely AI is a tool which all of us are using now. It is already there. It's not something for future. Lot of new prospects, new things are coming which will help us treat our patients better. However, what Mr. Geoffrey Hinton told, we need to be aware about that. Is technology becoming smarter than us is something we need to really think about.
Well,
it's not going. Next slide. Thank you very much. I'd like to encourage all of you to come for the 6th Retina Summit on ROP. Thank you very much.
Thank you, Rajiv. Before we conclude, and thanks to everybody for coming here. Before we conclude, we have Dr. Grant Redmond, President of Australian Ophthalmological Society. I would like him to say a few words, and then I'll request the speakers to come together. We can have a quick photo.
Thank you. It's an honour to be at this extraordinary meeting. I really enjoyed that session. I thought the talks were very balanced and cutting edge, so thank you to all of the contributors. Certainly it's a major public health issue. It seems to be an issue in Australia and New Zealand which affects our indigenous population severely as well. So the underprivileged and under-resourced continue to suffer in all societies. It's a major exercise, as you've just heard, in trying to screen these people, and I think obviously customised screening with AI will be the way of the future. The use of anti-VEGF agents is sort of probably something we do more generously in Australia than because we have funding from the government for it, as opposed to India where it's more resource scarce. So certainly I think you would try and avoid cataract surgery, posterior segment surgery on a swollen macula. We have the means of measuring that nowadays, and if we can get the IVI treatment and dry it out, then often do that surgery under IVI cover, you'll get the best results. We saw some very elegant vitrectomy surgery. I think when it's at the stage of such delicate segmentation, you are dealing with very sick ischemic retina anyway, so the outcomes may be an improvement in the anatomical configuration, but often they don't see very well. So it's too little too late, unfortunately, despite the elegance of the surgery. Laser, I would just reiterate, I think the talks were very, very good in emphasising don't throw the baby out with the bathwater in the modern world of IVI. I'm still someone who looks to see if there's focal leakage that I can actually laser, because I think that reduces the duration and frequency of the IVIs. I suppose the other tip is that the laser burns, if you are doing laser around the macula, will spread over time. People that have been doing it as long as I have somewhat are disappointed when I think I thought I'd lasered that lightly, yet over the years those burns get bigger and creep, but they often do the job. So I think at the end of the day, the armamentarians increased significantly in recent times with the advent of IVI and the recognition of deposteroid as being a solution for macular edema, whereas in the past we just were one-trick ponies with grid laser, which was of limited value. Thank you for having me as a guest. I've really enjoyed my time.
Can we have a quick picture with all the faculty, 2 minutes, and we are done.